We'll get started here in just a minute. I'm sure people are getting back to their desk, have grabbed their cup of coffee. Um, just want to welcome everyone for joining today. This is the CNO Roundtable. We're really excited about this series. So this is a series that we have created this year. And the reason that we created it is because we've noticed this emerging role of the Chief Network Officer, and really feel that this role that we've been seeing more and more of is an acknowledgement of how valuable and important the provider network is to health plans, to members, and to providers. This is actually the second of the four-part series. They're happening every Tuesday at this time. The first one was called Leading the Shift, How Chief Network Officers Drive Organizational Transformation. That one was really focused on the role itself and really what this emerging role signifies in terms of change. If you missed it, don't worry. You can catch it on the Andros website. You can also catch it through our LinkedIn page. I'm super excited, though, for the second in the series because what we're doing today is we're actually shifting to the provider perspective. So that's the title. It's the provider perspective, building better partnerships with health plans. I'm really excited about our two panelists today. Really enjoyed prepping for the session with them. They're both brilliant people, insightful. So without further ado, I'm first going to pass it over to Tarek to introduce himself.
Good morning, good afternoon to everybody. I'm Tarek Elsawy, and it's a pleasure to be here and appreciate being asked to be a part of this panel. So just by very brief background, I'm an internist by training. I've spent first 17 years of my career at the Cleveland Clinic, or my last two roles there. One, I started the clinic's clinically integrated network, and then I was the chief of operations for the clinic's regional hospitals and all the family health centers. I then went to become the CEO of Reliant Medical Group in Massachusetts, and spent the last 7 years after that as part of Optum Health. And my last role there was as the president of the Northeast and Midwest regions. And I had the pleasure there of connecting with my good friend Melissa. And we had the opportunity to work together. So any opportunity I have to work with Melissa again, I always take it. And after I left Optum, I became the CEO of a medical group, the largest nephrology practice in the country, called Panoramic Health, and loved the time there. And I think you'll find that one of my callings now, and one of the things I've become really, really passionate about, is how do we actually enable providers to do the work that I think they are most passionate about, which is actually taking care of patients. And so now I'm the executive vice president of a company that's based in San Francisco called Emerja. But overall, it's a pleasure to be here, and I appreciate the interest in the provider perspective.
Wonderful. Melissa, you want to go ahead and introduce yourself?
You bet. Melissa Kittleson. I'm the Chief Transformation Officer at Andros. I spent close to 28 years at EY, leading their Central Region Health practice. Spent about 20 years as the global coordinating partner for United Health Group, and then ultimately retired, started at United Health Group one day later, and really helped them in their Optum Health transformation journey, where Tarek and I crossed paths and actually worked very closely to try to pivot Optum Health and focus on the patient and provider experience and align all their assets along that way. So thank you for allowing me to be here. Tarek, likewise, very fun to banter with you today, and I hope the audience finds it very valuable.
Awesome. So as the audience can tell, we have two people who have a lot of experience helping very large organizations and all kinds of different organizations really transform the experience between payers and providers, which is all of what today is about. Real quick logistics before we dive into the conversation for people listening in. We will take Q&A at the end. So as you're listening to the panelists, if a question pops into your mind, go ahead and put it in that Q&A panel. And again, we'll get to those at the end. We'll leave plenty of time for that. So first question is actually coming to you, Tarek. From your perspective, having been a provider, working with payers and working around networks with health plans, what are some of the biggest pressures you experience in working with health plans?
I think I would tend to bucket those, Louise. So the first bucket is what I would call the transactional bucket, which is, at its simplest form, plans get patients, patients come to see the provider provides a service, and the expectation is that they'll be paid for the service. And if you sort of follow that stream, there's all kinds of things that happen that may not seem all that complicated, but they're incredibly complicated. And the thing that I think leads to the biggest frustration is things in that realm. But I think there's actually a much, much bigger issue. And I think that's the issue that if I was in the role of a CNO at a large plan or any plan, is getting to the point where you acknowledge this relationship has mentally broken. And there is a profound amount of frustration from the providers. There's frustrations from patients. And there's also, frankly, frustrations from the providers, from the payer side, right? Because there's not a single, and I had the privilege of working with some of the finest folks in the payer world, brilliant people, who their intentions were all really good, but there was a profound disconnect between them and the patient and them and the providers, where they effectively were cast in this role of this unwanted middleman. And I think that's really the work that's ahead. The good news is through, I think all of us are intimately familiar with a lot of tragic events that happened, that there is no excuse on God's green earth for any of those things. But I think we all need to listen carefully to what patients and providers are telling us and how do we navigate this next phase, because all three are essential to make this ecosystem work.
I think that's a really great point. We spend a lot of time focusing on the transactional, right? Because that's where we spend a lot of our days and minutes. And I think the kind of call to action to focus on fundamentally fixing the relationship and everyone kind of realizing what they're accountable for and what members and patients need from each of us, because that's ultimately we all serve, right? The member and patient at the end of the day.
And I think having the courage to actually acknowledge it.
Mm-hmm.
A lot of times, you can't fix a problem unless you acknowledge it exists. And when everybody enters a conversation thinking, oh, everything's business as usual, you've kind of are a little bit behind the eight ball on both sides.
Absolutely. So I remember when we were preparing for the session, one of the things you talked passionately about is, right, one of the ways to kind of influence providers is to realize that they care about patient care. Do you think that health plans can help move the ball forward in terms of patient care? Or do you think, kind of to your earlier statement, they're kind of middlemen? We need them to get out of the way. What is their role in helping with patient care?
I think it depends on how you define health, right? I think one of the things that has occurred because people were searching for solutions was to sort of evolve into this pay provider world, right? Where you're the payer, you're the provider. And the reality is, I don't feel providers are very good payers, and I don't think payers are very good providers. I think the ability for us to have folks focus on what they do best, and this is where I'm finding some real intriguing things that are happening now. I think the best payers are recognizing their job done at the highest level is to actually be the facilitator for the providers and patients, not for them to sort of insert themselves in a world that neither the patient nor the provider particularly welcomes, right? You don't want to be going to a party where you're not invited. And a lot of times patients feel like, why am I getting another call from plan XYZ? I don't even know who they are. And they, Melissa and I used to talk about that all the time. Think about all the money being spent on some of these quote patient engagement things. The folks that patients really want to be engaged with are, can you provide me a service that my provider can't? Can you help my provider do something that they can? Can you be engaged in technological solutions through my provider that allows me to get better care? I think all those things are imminently in the domain of the payers. And I'm a really optimistic person by nature, but I actually am starting to see some payers thinking about the world in a very, very different way, which to me is wonderful.
That's great to hear. Melissa, I'm curious to hear a little bit from your perspective. So, like Tarek was saying, right, health plans that feel caught in the middle. Health plans, though, payers, right, they have a tremendous amount of power, right? They really have the opportunity to kind of reshape financial landscape, right? So they feel pressure and but have an ability to make sure care is affordable to control costs. They also, right, can influence quality. They can influence patient outcomes, and they often feel a lot of pressure to do that. Um, are you seeing places where we can create kind of a win-win here, right? Where we're creating value for the plan, we're creating value for the provider, we're creating the best experience for the member?
No, I do. And I think, Tarek, you hit it. Health plans and providers are really often framed as being at odds, but they actually share the same ultimate goals: improved outcomes, better experiences, and responsible use of resources. So, Louise, to your point, the win-win comes when both sides can co-design and really co-create solutions based on data transparency and aligned incentives, which really includes shifting away from punitive cost controls and really moving toward the value-based arrangements that reward outcomes, access, and your patient experience. So, you know, um, we had a regional health plan and multi-specialty group where we launched a value-based initiative targeting high-cost chronic patients. We created shared dashboards that tracked avoidable ER visits and follow-up appointment adherence. And literally in just 9 months, the plan saw a 12% reduction in the avoidable ER usage. And more importantly, the provider group also improved their quality bonus. So, it can be done. It's just as Tarek mentioned, it's just a shift in maybe how you're designing and how you're creating where your payers are well intended, but a lot of it's being done to the provider versus with the provider.
Awesome. And Melissa, you have a lot of experience really being on the ground for these types of transformation initiatives. I'm wondering if you can describe a little bit more. What does that relationship look like? What does that process look like? You used a design thinking term, co-create.
Yeah,
Some people in our audience may not be familiar with that concept. Can you describe that a little bit more?
I can, and Tarek knows this very well. I think this is how I started working with all of the regional providers. I am a true proponent of a cross-functional team in almost everything we do. So, how do you create not just provider thinking, but actually take some providers, put them together with the plan administrators, even some of the people at the front desk? How can you get those folks in a room, really talk about the issues that they're encountering, go away, come up with the solutions, and then bring it back to design working sessions so that you can co-create this together? And that was a big word that we use at Optimal Health Evolution. Some people liked it, some people didn't, because it took away some of the power of those that really just wanted to mandate a change versus co-develop a change. So to me, that ideal partnership, it's moving away from the episodic contracting conversations, and it's embedding that cross-functional provider plan teams that meet regularly to proactively solve problems and co-develop those solutions.
I love that. I love that you mentioned too, including the administrative staff, right? That's an important thing is, right, providers are not sort of monolithic. They have different people performing different functions too. So it's how can the administrative staff at the provider help me? How can I help them? How can the clinical caregivers help me? How can I help them? I love thinking through that whole ecosystem. So Tarek,
Please, can I piggyback on Melissa's comment for
yeah,
just one second? I think if there's nothing else for the rest of the day or the rest of the hour, this concept of, and I used to sort of talk to Melissa, I go, look, and if you want to do this without getting your hands dirty, just stay in Minneapolis or wherever you are and don't bother. The way that you actually become ingrained in the provider world is, guess what? Be in the provider world. And I think there is a degree of humility that comes with it, because a lot of folks are, well, we have all the data, we know what you're doing, right? No, you don't. No, not really, right? And if you really are interested in solving your problem, it's not dictating the outcome of the problem. You need to be there, and I think that's one of the things that I would strongly urge, especially folks who are sort of in charge of the network, right? Who are in charge of they should spend way more time with the providers than with their own colleagues.
absolutely. It's critical to understanding, again, the member and patient experience
Yeah.
too, right? Understand your customers, understand members, and understand providers. I love that. So Tarek, I do have a question for you, actually, really in this vein. One of the things that we were talking about when we were having a discussion ourselves is that another thing that can sometimes hold us back is it can be pretty difficult for health plans and for payers to innovate. And you talked a little bit about how important that experimentation and failure cycle is to innovating. So I'm wondering if you want to just maybe share some thoughts on what do you think maybe holds plans back a little bit. Are there things that they can do to step forward, right, into this new type of relationship that you and Melissa are describing?
I think I appreciate the question because one of the things that I am absolutely convinced of is if we just insist on refining exactly what we're doing right now and doing nothing different, well, you're going to get the same exact result. Nothing's going to change. And it's just going to lead to more entrenched views that don't serve anybody. I, Plans are but inherently really complex, typically really large organizations that have all kinds of things that are happening to them and all kinds of layers. And I joke that I've happened to work for one of the largest health systems in the world and one of the largest payer in the world other than CMS. And the layers and the number of things you have to do to get things done are by necessity complex. And I think if I had one recommendation, and the things that I saw that really worked is everybody goes, well, can we scale this? Can we do this? I think sometimes it's just okay to sort of say, you know what, we're going to try this in this market because we have a really great relationship with the providers there. I understand what they're trying to do and solve a very simple, like solve a definable problem. And I think people they go in and say, we want to solve readmissions, right? Oh, readmissions sepsis by itself, sepsis readmissions by itself is a $50 billion problem. Okay. So when somebody goes, I would like to solve readmissions, it's such a big, broad statement that people kind of just nod and go, yeah, so do I. I'd like to solve a lot of things. But having a defined small problem that you can work on in a market and we all have bosses. Nobody wants to go and say, I did a failed experiment. Like nobody starts off their day by saying that. But if you have a small defined problem, and I underline the word defined, and you have some metrics that you can attach to it and say, here's what we're going to deploy this technology, or we're going to deploy this operational change or this clinical change. And we're going to monitor it for the next 3-6 months. And we'll report back to you, and we will continue to keep working on it rather than this big, huge, grandiose thing that I have to sort of do across the entire country. Because guess what? You tend to know, like within 3-4 months, if whatever you're doing is working or not. And if it's not working, just stop. Say, you know what? Great. Let's do the next one. Right. So I think it's that ability to be willing to fail fast and fail forward and not feel like you need to tackle the entire planet in one day.
Couldn't agree with that more. I actually, on some of the innovation teams I've been on, we set both success criteria, which
Yeah.
most do, but we also set quitting criteria, right? Which is when are we going to quit? What are going to be the signals, and how do we
Yeah.
know when it's time? So,
I mean, if I'm selling lemonade to thirsty people, the experiment's going to work, right?
yeah.
If I'm serving, boiling hot coffee when it's 95 degrees outside, maybe not. So I think it's that. And I love the sort of quitting criteria. To me, it's like, if you don't meet certain thresholds, just go, you know what? This was great. I learned a lot from it, put it in the bullpen and go to the next thing.
Yep, yep. I feel like the world of technology needs some advice with you too, because if I look myself in the mirror, having worked for tech companies and healthcare for a long time, I think we probably have some of the same problems, right? Tech companies saying, I'm going to fix not just readmissions, I'm going to fix healthcare. I'm going to fix healthcare.
Yeah.
Right. And so I'm curious when you think about, technology, certainly there are places where technology has been able to come in. It has been able to transform patient care. It has been able to transform healthcare operations. There's also probably some places where it's just added complexity, right? Or it hasn't had the ROI that was expected or needed. So I'm curious, and I know you work in a very sort of, tech forward business right now. What do you think it is that we need to make sure that technology solutions are really hitting the mark and are building value, not just contributing to fatigue?
Less hubris and more time with the customers. Exactly the same advice that you sort of do with payers,
Yeah.
because a lot of time people say, "Oh my God, this thing has all the sophisticated technological," and people are going, "Okay, I really don't care how cool your back end stuff looks. All I know is what I'm seeing makes no difference in how I'm taking care of patients, right?" And I find that the really great technologists are some of the best listeners I've ever been around. They just are inherently interested in going, I don't need to solve my problem. I need to solve your problem. And I also think as some of the technology comes out, this is where I would also push on my provider colleagues. There's always like I spent time at Hopkins, and one of the sayings that kind of embodied everything was, there's the Hopkins way and there's the wrong way. And that permeates so much of a lot of healthcare institutions that it's dangerous, right? Meaning you have to be open to doing things in a new way. You have to be open to doing. So that's the push that I would sort of push on the providers, but the push that I would on the technologists and the folks trying to solve some of these problems is please ask them what problem they're trying to solve and how do you help them do it. And the most classic example of this, we're all completely wed to EMRs, right? EMRs were not designed to provide clinical care. EMR were designed as a billing system, right? And we're still living with that impetus right now. If you, and I would challenge any of you, walk into any large provider group and ask them, how many of you love your EMR? Not a lot. Not a lot. I was very, very fortunate in one of the organizations I led. We had a brilliant physician who was really a technologist, right? He picked the wrong checkbox off his application to medical school. He really should have been purely just in technology, but he really understood the physician world. And we had the highest physician satisfaction with that EMR because he tweaked the living daylights out of it, much to my frustration, because every time he tweaked it, it cost me more money. But I realized, like, oh, we're actually getting better productivity and I'm getting physicians who are happier using it. So I think it's just that engagement. And again, get your hands dirty. Be where the action is, not where you're creating a beautiful, Melissa and her team could create some of the most fabulous PowerPoint slick things, facilitated, just absolutely, world class, where there's a little bit of ooh and ah kind of feeling to it. But the reason that it really resonated with me and my team wasn't that, right? Because we had plenty of people that could do that. But what it was just sort of the curious questions and the setting of timelines and the setting, to the earlier point, what are success metrics and what are metrics that say, hey, we're just in the wrong time, wrong place, but we'll move on and maybe we'll come back to this, but not now. So I think it's, again, that really engaging with the local environment and not presuming you think you have the answer or even know what question they're really trying to help you solve.
Yeah, Melissa, I'm curious, what's your thought on what Tarek's talking about? And is there an opportunity for health plans to help? Can they help be the bridge to technology innovation? Can they help be the bridge to better patient care?
Absolutely they can. And the biggest gap is often not the technology itself, but it's that lack of provider input in its design and its rollout. So, innovation that adds administrative burden or disrupts workflow, even if it's well intended, it's going to undermine your clinical outcomes and your trust. So, you know, a lot of the perception is, oh, your providers, they're not technology savvy, so we're just going to build it for them. We need to spend more time in the design sessions, really hearing and listening to what the providers need. And then before it's completely developed and rolled out, iterate on it, bring them in, do some demos. To, Tarek's point before, do some pilots. If you're going to fail, fail fast. Don't fail with a whole, rollout across, the nation and the globe, but but really take the time to make sure what you're building is gonna be the result that you're looking for in the outcomes, in the reduction of your administrative burden for your providers, because your providers are your greatest assets. And I think that's forgotten a lot. We talk a lot about the patients, we talk a lot about the payer. Sometimes we forget that the providers are really your largest asset. So, to me, and I know you're going to hear me say all day today, that co-creation, co-design, and really co-sponsorship, that's how technology is going to work, because you've got great people coming together. And I can barely turn my computer on. But I do think, the technologists really can understand what the providers need if they take the time to listen.
Yeah. Both of you too, the call to action to physically get out, right, and go spend time in the space, I think is really important. I think it's easy when your job, like my job, is pretty much sitting in the same spot all day and staring into a screen all day. It's easy to actually underestimate how physical the practice of medicine is, right? You're hands-on with patients, you're moving around a physical space. And so assuming that people can just, dial right into their computer screen at every time is not actually the reality. So I love that idea too. And I imagine, Melissa, part of it is too, then when you're doing rollout, having this knowledge, right? This kind of intimate knowledge and detailed knowledge of what it's really like is going to help with rollout and credibility there.
Absolutely. And Louise, to your point, and Tarek knows this well, we spend a lot of time in the field, even just understanding, what makes your company special, and basically what are the challenges you have. Spent a lot of time listening, and even had to modify our plan many times because what we thought was very different once we took a visit. So I can't stress that enough. You got to be in the field. You got to spend time with the people at the front desk. You got to spend time with the people that order the surgical equipments. You got to spend time with the providers and your nurses, and all of the above, not just the physicians. So that's kind of my message.
Yeah. And
As
not
a
to,
physician, I would say amen and amen to that, because we're just part of a team, right? And I think people recognize pretty quickly that it really is a 100% a team sport.
Yeah.
And being able to spend time with that whole thing, it really improves your perspective on what the real answer is.
yeah. One thing I'm curious to hear, and I'll throw this one open just as a follow-up to what you're suggesting to both of you. One thing I found is that sometimes folks' intuition about where the differences lie can actually be incorrect. You know what I mean? So, for example, I can imagine if I'm a health plan, I'm really wanting to spend more time with providers, understand the market. Do I focus on um, specialists versus primary care? Do I try to get a nice cross section of larger, right, clinical organizations versus some independent practitioners? What do you think is going to really matter in terms of not lumping everybody in the same box and making sure you're also understanding breadth of experience, or maybe it doesn't matter, you know?
It's enormous, enormous. I think one of the things that is absolutely critical is to really think, if you were dealing with me at the Cleveland Clinic, it's really different than if you're dealing with me with a much smaller group that I manage that was in Indiana.
Yeah.
It's also going to be really different if you're dealing with me with a 2,000 provider group that's in Massachusetts, right?
Yeah.
They're very, very significant degrees of difficulty, and there's all kinds of different interests. I think one of the things that I want to sort of think in terms of because the concept of piloting and facilitating, to me, that's something that's very near and dear to me. If I'm a plan and I know there are some groups of folks that are really, they want to be on the leading edge, or the bleeding edge, whatever way you want to describe it, I would be pouring a lot of energy into them.
Hmm.
Because if you get them to say, hey, this really improved our ability to take care of our patients, this really improved our ability to have better outcomes, this actually reduced my friction costs during the course of the day. If you get them to say that, that is better than any 100, 200, $500,000 marketing plan at creating provider engagement. Like literally having specific people and specific organizations become your ambassadors, not your shills, but your ambassadors.
Yeah.
If they can speak about this in a way that's really meaningful, it's priceless. It's
Yeah.
priceless. And that's sort of always been whatever modicum of success we've had in terms of innovation. Melissa knows that I was very fortunate to lead one of the most, if not the most innovative group. Was you allowed people within that group to innovate. And when they did it well, you go, okay, you talk about it. I don't need to talk about it. You talk about it. So again, finding sort of people who would be great ambassadors for a pilot that worked, and sometimes even for a pilot that didn't work, because they'll say, "Oh my God, Plant XYZ was so great. We knew what we were going to start off with. If this happened, they were going to continue to support it. If this didn't happen, we would both agree to dissolve it and look for the next thing." So find some champions.
I love that. That's great advice. My next question, Melissa, I'm going to throw to you, but then Tarek, I'd actually love to hear your perspective on the same question as well. Melissa, on the first session, we ended up having a pretty enthusiastic conversation about what I think one of our panelists dubbed like the, sort of most underutilized leg of the, provider life cycle, which was everything after contracting. So, right, there tends to be a desire to really focus on contracting because that's going to set the legal and the financial relationship between the two organizations, and that's where the rubber hits the road and actually structuring the network. But then there's this whole, right, some people call it provider relations. That group started calling it provider experience, partly because they were talking about the need to shift from something that's very reactive to something that's very proactive. In your opinion, what are some of the things that you think we could be rethinking in terms of what provider engagement looks like, provider experience looks like, performance looks like, and that whole world, post-contracting once they're an actual partner?
Well, I think you hit it on the head. Many today provider relations groups still are like the firefighters, right? You're addressing issues only after they're surfaced. So, as you really think through that proactive relationship, how do you create a group that continuously listens? They're supporting the operational excellence and really helping your providers navigate complexity. So, as I think through some health plans that do it well, they've created this concept of like a provider concierge. So it's a team that's trained in operational navigation, their tech tools, and even the reimbursement models. And that team really has been able to reduce the provider escalations by 40%, really within a couple quarters, and boost the provider NPS scores because their capabilities are different. Like a customer success team in tech, these provider success teams have to be savvy in storytelling and empathy driven engagement and change management. And they really need to be measured differently: provider satisfaction, retention, and performance improvement versus just a payer type metric like a call resolution time. So, to me, it's shifting the function of the provider relation group and the measurement and the pay and the bonus structure to really get after the outcomes and the experience that you want with your providers. And I think in doing that, your retention is going to increase twofold. So I don't know, Tarek, what you have to say, with that, but that's the way I'm thinking of it.
Couldn't agree with you more.
That's great. And I'll say one thing that we're starting to see, just to Tarek, tie in some of your earlier observations about create many different pathways for engagement. If I'm working in a Cleveland clinic or I'm working at right, I'm an kind of independent, that engagement experience can look really different, right? The way
Oh,
we're reaching out to them, right, the way that they, what we tend to see, for example, is we see people interacting with our systems if they're an independent, like a behavioral health, they don't actually have a front office. So we actually see them engaging with our systems at like 2 a.m. I just feel really bad about, right? But that's they don't have a front
yeah.
office and they appreciate the digital pathways to interact. So I think that there's some connection there to Tarek, to what you're saying about create different pathways for different types of providers, different needs through that provider engagement experience. Yeah. And Melissa, I'm curious, how do we connect strategy to post-contracting experience? So when we're building a network, we tend to be thinking a lot about, okay, who are my, kind of linchpin foundational providers? Who are the providers that I think can become part of a, high value, high performing network? And what we sometimes hear clients say is sometimes that gets a little lost in translation when it comes to execution, when it comes to provider relations. What do you think are some of the opportunities there?
So one, I think we have to start treating our providers as strategic partners, not just contracted entities. And you still hear a lot about contracted entities, which means you're not considering them as your partnership. How to, engage them in shared planning. They don't have to be involved in the entire weeks of planning, but again, have a design session where you're talking about, before you already put into place, what are the incentives that you're offering? What is the communication channel? What will your provider scorecards look like? And do we need some kind of quarterly listening labs to make sure that we're bubbling up some of those challenges? So, engage them in the shared planning, offer transparency. And I think, to me, Tarek, I'd love your perspective, but transparency is key. And even when your health plans mean well, they try to shelter the providers from actual results because they need to have time to serve patients. Providers need to have transparent information. And then I would reward collaboration. It's not just about the rates, it's really about respect, responsiveness, and results. So I don't know, Tarek, what you would want to say to that?
I completely agree about the transparency part, because I think sometimes people react to some providers like they're there, don't you worry your pretty little head about it. And what they don't recognize is some of the providers now, this is not sort of there's a lot of us who have been physician executives for 20 years and have been at really sophisticated places, and I didn't do this as a hobby. This was our job. So when people come in without a frank discussion and a transparent discussion, we know it right away. And it sets the tone. And you're going, okay, you think the negotiations were going to be hard before? Wait, because at the end of the day, patients don't go see a payer, right? And especially if you have a really well-run physician group. I'm not talking about, if you're in Northeast Ohio and you're trying to somehow figure out a way, oh, I'm not going to have the Cleveland Clinic in my network. Well, good luck, and I hope you're managing your extinction well, right? That's not going to happen. But there's lots of other really, really smart groups that if you actually share with them, hey, this is the problem we're trying to solve. Do you think you can help? It's never presented this way, right? As if like we have all the answers. No, the reality is, you know what? Your star ratings suck, right? And guess what? We're the folks that can really help you with that. So let's think about a way to solve it. And if there is a technological way to improve it, if there's a direct contact way for us to improve it, there's all kinds of things. But I love this concept of transparency. And this is why the co-creation, co-design concept is critical. Because if all of a sudden you tell me, hey, Tarek, I need you to do this. I need you to paint this blue. I'm like, okay, well, it's just as easy for me to paint this blue as it was to paint it red. So fine, I'll paint it blue for you. And if that solves a big problem for you, all the better. So I think the transparency is essential on both sides. And there are some payers where I was very fortunate that you were able to sort of go, all right, this is killing me here. And it wasn't about, rates. Rates always come into it, right? But it was about like this process that you guys have in place is literally killing me because everybody that engages in it hates it. Can we move on from that or do something different? Oh yeah, that wasn't that big a deal. Just we thought this would make it more efficient for you. So it's just that time and the ability to spend being really transparent and being really, really honest. I think that's enormous.
Yeah, Tarek, I think the other thing that we found is, when you really take the time to co-create, the adoption and the success of that process you created together, it's crazy. So, for an example, we were told there's no way we're going to come up with common benchmarks across all of our different physician groups. So, Tarek, what, 6 months, 9 months, we came up with the top 25 metrics across the entire thing. And the only reason we did it is because we took someone from every region and we sat in a room and we did it together. And the power of that is just absolutely huge.
I love that. And I think that's actually something, just to spend another minute there, that's actually something that most health plans I know either are doing or aim to be doing is some sort of provider scorecarding, right? Is often the phrase that's used. And it's really about helping providers understand performance. That's one of the things that plans I think can do well, right? They sit on mountains of data. And so what they can do is they can provide insight into benchmarking and what else is going on. How do you set that up though, that it doesn't feel like, right, that it doesn't feel overly kind of paternalistic or right sort of the health plan coaching the providers because certainly again I think the theme of
Well,
this
Louise, you just triggered me.
did
So,
I I have a habit of doing that Tarek, right?
so,
It can be
so
a
that
gift but it has to be
concept
treated
of,
right.
yeah,
Yeah.
so this is, whenever payers talk about provider scorecards,
Hmm.
first I do what everybody tells me is take 2 deep breaths, like don't just because it is profoundly like actually insulting, right? And I'm going, you know what? I actually have a payer scorecard for you to look at, and you're last on my list also. And I think the further we move away from quote, a scorecard towards this is something we both agreed were an important metric, and
Mhm.
how are we performing against it? How are both of us performing against it? The further off you go, because whenever people say, "Oh, did you see the last scorecard that I sent on all of your providers?" I go, "No, I really didn't."
Yeah.
And, so it's just even the wording of that. And I know it sounds like a really small thing, but it just starts off the conversation in a really, really different thing versus like, hey, we're really trying to solve readmissions secondary to reinfection or you know any of a number of things. That's so different because you know what, that's focusing on what I should care about. I don't want my patients getting reinfected, right? And
Mhm.
if we're performing here and there's another group that's performing here, please tell me what they're doing, right? But that to me is just, it's a stylistic thing, but I think it's a really, really important thing.
So Terry triggered a really bad engagement I was leading many years ago. Um, and I was asked to develop a scorecard from the payer side. And so 15 years ago, I walked in and, I had this scorecard and I thought it looked pretty and it was great. Um, and I got yelled at very loudly from someone on the East Coast about how it was a piece of not art, but maybe on the opposite. And, I sat there saying nothing, trying to figure out how I was going to recover from this. And all I said was I took it and I ripped it in half and I put it down. I took a white sheet of paper and I said, do you have time to help me create what would be meaningful for you? And that scorecard looked 100% different than anything else. And it was adopted broadly over time, right? I had to go back and, get yelled at by one group that it didn't look like what they needed, but ultimately it was valuable. And I wish I could remember what we actually called it because we didn't call it a scorecard. That was the first thing we did is we changed the name, and it was really a meaningful report that was built for the provider and then just ultimately went to the payer. So um, I still remember getting yelled at. So I'll recover after this is over, but I haven't thought about that in a really long time. I think he actually told me my engagement got an F. And then by the end, I was up to a B plus because he said he didn't give out A. So, it was a really good trend. But it was a painful experience because I really thought I came in and I had this all together. So it just, if you take the time to listen, it actually was a really meaningful piece of work. So
I like that story. The script was flipped on you. You went from scoring them to being graded yourself. So
and I don't get a lot of F's in my life. So I
I can imagine. I can imagine that drove you crazy. Well, believe it or not, this conversation is going very quickly. I want to save some time for Q&A at the end, so I'm going to ask just one more question, and I'd love to hear from both of you on this. But I really just want to kind of give you the floor, starting with you, Tarek. If we do have a fairly health plan heavy audience. We do have some providers in the audience as well. But if you wanted to kind of leave with a piece of advice, both to health plan leaders and maybe also provider leaders, what's the bit of advice you'd leave them with today?
I think we covered a lot of it. I think the one thing that I would just overly emphasize is acknowledge there's an issue. Don't pretend like everything is the same. It's not. To spend time with the providers, and for my provider colleagues, listen with a truly open mind and understand that actually your goals are really not that far apart. What each of us does is radically different. And I would say the last thing is for the payer community and the health plan community to really, really think deeply about how can we utilize all the incredible resources that we have, and how do we start actually making small, successful experiments that we can sort of start to see them flower across a wide range of scopes, and make it small, make it tactical, and just get started. Like, this idea of like, well, it's just been validated in 25 states, and like, no. And it's that type of thinking. It's really hard to people to leave the paradigm that they know, because paradigm shifts are by definition only happen when the people who are holding on to the old paradigm die away. And that's literally what happens. I mean, for places that are not embracing technology and are not embracing different ways of doing it, I wish you luck.
And then Melissa, I want to give you the floor as well.
Well, Tarek took a lot of what I wanted to say, so let me.
She knew I wasn't smart enough
You
to
just
have
say
to
ditto.
she knew that.
Just the one thing I would add, Tarek, and I think you would probably agree, is the health plans often underestimate the unintended administrative burden they place on providers. I just don't think they understand that a fast process that requires your providers to now dictate versus something else has consequences. And then I'd say on the flip side, the providers assume that the health plans are purely just cost driven. So I think the mutual agreement and meeting of the minds that both are working to manage risk to improve outcomes and make sure we have the best experience would be very helpful. So a more strategic, aligned relationship with the providers and the payers working closely together. I think that's the magic that we've started to see, and I think we're going to see more of, because we have to.
Love that. Well, thank you both. So we're going to go ahead and turn over to Q&A. We've gotten several questions. We're going to try to get to as many of them as we can. If you're in the audience and you asked a question that we don't get to, we'll do our best to follow up with you. But here's one that I like coming in short and sweet. Just because someone is a physician does not mean they are a good physician. So Tarek, I'm going to hand this to you first. What steps should payers be taking to ensure that their networks are high performance networks?
So I think that's actually a great question. And the steps that I would take would be to actually, while a scorecard is, going to be a difficult topic, but I think benchmarking against other physicians, and then maybe sort of subtle change in wording, and people say, oh, that's the same thing. This is where we're having a real relationship with the provider group to sort of say, hey, look, you have 100, just make the math easy. You have 100 providers. 90% of them fall within sort of the standard deviation of whatever thing we're measuring. But there's a group that isn't. I would love your help in helping us get them to either fall within the standard deviation, or frankly, you may need to look at this from your own perspective as the CEO of a bunch of medical groups. Trust me, the idea of me having a substandard physician was my nightmare, right? And the process of sharing the data in a way that's really like, this is just fact. This doctor's surgical readmits after they do a procedure is X, the rest of the world is here. There's a difference. The prescribing habits for this physician is here. Their utilization of X, Y, Z is here. That really also stems from the fact that you have a trusted relationship with the leadership of the medical groups that you're dealing with. And that's where coming in and working with them, having spent time with them, really comes in. because at a certain point, you need to show people real data. They may argue with you about the data. They may say, oh, this is skewed. And, I've gone through all the various phases of death and dying with providing providers with quality data. And, and this is internal. Has nothing to do with the payer. But I think sharing that data, sharing it benchmarked, and having a relationship with the leadership of those organizations is the way that I would
Tarek, I like that. And I think the other thing I think about too, I've got a lot of family that is in the provider world too. And I think we all know there's a shortage coming. And I don't think we take the time to really understand why the metrics are the way they are. There's a lot of decisions that are really just based on reports. And I think understanding more what it is, maybe someone is stronger in a clinic than they are in a surgical piece. And that's okay. Maybe you need to just say, okay, here's where you're going to refer your surgical, consults, and just keep them in the clinic. And I think it's kind of an all or nothing. So, I'd go back to making sure those provider relation groups or whoever's looking at it has time to really understand the root cause of the issues before they just start, making some key decisions.
And I think, just to piggyback on that, the payer community has enormous amounts of data and some really wonderful people who can cut and slice the data anyway. Because if I'm presenting Louise with data and saying, hey, Louise, you're performing here and, your standard deviation above or below where you should be. The first thing Louise is going to say, well, I don't even know what you're talking about. Like, where is that related to? Or is this even comparing apples to apples, et cetera? All the usual things. But as a payer, I can come in prepared and say, hey, in 100 folks who serve in the same exact community, same type of practice area, and here's where you fall. Here's what we've noticed, right? That is a really, really powerful discussion. And it's a discussion that's not really from the payer, it's from the leadership within their own medical group. Because no matter what, they're going to view you as an outsider.
That's a good point.
Next question for you, Melissa. Another short and sweet one. What specific strategies would be helpful for providers who are resistant to adopting new technology? I know you have lots of experience getting technology uptake where there's some resistance.
Well, it's funny because everything is self-service. And, one thing that I thought that worked really well is making it not so self-service. So, as you stratify those that are scared of technology or that need more help with technology, there's different ways to do it. So I don't know, to me, we've had to do a few workarounds, but technology is not going away. So, we kind of got to think through what works and bring that provider group in and really say, what are the challenges? And then maybe you have to customize or do something different for those that can adopt. So I don't know if that's really a good answer. Technology.
The only other thing I would add to that is this is, again, we're having champions who've used technology and used it successful, have them speak to those providers.
Absolutely.
That becomes a
provider is probably better than having a health plan technology group provider. So the more we can, that's why I was kind of getting to the two in the box with your technology and your provider group. Providers are always going to respect the opinions of other providers. So Tarek, that's a really good thing to draw out. That's the better way to go about it on just about everything from a provider relations. So those provider advocacy groups and councils and joint committees are going to hold a lot more weight than just the health plan executives talking.
Agreed. That's a recommendation I'll definitely be taking with me from Tarek. Is even better when it's coming from a provider's mouth versus your mouth. Question really for either of you. So there's someone who's commenting. They really love the point that you were both making about payers using some of their power to drive real change. Any specific actions that a payer can take, knowing that they're pretty slow moving, to start moving in that direction now? So again, Melissa, I know you spend a lot of time thinking about transformation journeys. Imagine you're sitting inside of a large organization and you feel you're kind of at the front end of your journey of right, trying to perhaps get some buy-in for that kind of change. What are the first things someone in that position should think about doing?
Honestly, the health plans just need to open up some of their groups to include the providers, or at least a provider delegate that they trust, to really be part of the change. A lot of times the change is done to them and not done with them.
Yeah.
So, I know a time is of the essence, which is why, if your providers often will bring a delegate or someone from their clinic or someone that they trust to, really understand and make sure their voice is heard. I think it's as easy as that.
Yeah, because then you start listening, understand what needs to be done. You don't need a lot of budget, you just do it. Great, quick change people can make. Any thoughts from you, Tarek, on that question?
I think some of the stuff is just going to require courage, to be honest with you. And that's always hard in really complex organizations. But I think that if I'm sort of in the role of somebody who's responsible for a network and I have my, one-on-one with my EVP or my CEO or whatever, I would say that they need to be also leading that charge. And because when they do that, that sends a very subtle message, not just for the poor folks who are responsible for the network, but it sets a message to the rest of the folks like, hey, your job is to actually really help them, because without providers, all of us are doing other things. Right. And I think it's sort of having the courage to get the CEOs and the EVPs of large health plans to kind of go, yep, you know what? We clearly know we need to swim in this path. And it's not just about saying, oh my gosh, we've discovered the coolest new revenue cycle widget that, like, yes, it's important, but it's not going to be the thing that moves the needle materially for a health plan. Getting reductions on on getting the right clinical outcomes will have a orders of magnitude better impact on the health plan than any efficiency that they'll squeeze out.
Right.
I think that's a great call to action. So we're almost at the top of the hour here, so we're going to go ahead and wind down a little bit. Again, if you asked a question and we didn't get it answered, we'll reach out to the panelists and get you a response on that. Really appreciate the panelists today. Big round of applause for the both of you. Wonderful conversation. I loved it. For folks in the audience, just know that we'll be back here again next Tuesday. We'll be shifting from the provider perspective to the member perspective. If you have not signed up for that, or if you would like to encourage other people in your organization to attend, again, you can find the invite and the sign up through Andros' website. And as always, please feel free to reach out to marketing if you have any concerns, any questions, or are interested in getting in touch with Andros. So thanks, everyone, and we'll see you again next week. Bye-bye.
Thank you.
Thank you.